Hi, I am Dr. Vishal Babu. Let's discuss about the disorders of heme synthesis and porphyrias. So, the objectives of this session would be the acquired disorders or the acquired porphyrias and the congenital disorders or the congenital types of porphyrias. So, before we go on for porphyrias, we need to know the difference between the porphyrins or porphyrinogens. So, these porphyrinogens are usually chemically reduced, because of which they are usually colorless, whereas porphyrins porphyrins are intensely colored and they can emit light. So, that means any accumulation of these porphyrins and where they are exposed to sunlight, they can emit fluorescence. So, even in case of any teeth, it gets accumulated in the teeth, it glows at night. So, there are types of porphyrias. The first one is the acquired type, which is called as the lead poisoning, and the congenital type, which is mainly because of the porphyrias. So, we have studied the different enzymes in the heme synthesis. So, deficiency of these heme synthesis enzymes leads to congenital porphyrias. This has got many problems both in hemoglobin as well as cytochromes, because heme is very important for many of the functions in our body. Always remember this acquired lead poisoning, the acquired type is the one which has got anemia, whereas in congenital type of porphyrias we do not see any type of anemia, but other symptoms, other manifestations are being seen. So, coming to the lead toxicity, the pathophysiology of this lead toxicity is it mainly involves a compound with a sulfhydryl group. This sulfhydryl group is the SH group presenting proteins or the enzymes. So, that means lead involves many of the enzymes which contains this sulfhydryl group. It not only involves the enzymes of the heme, it also involves the enzymes of many other systems as well. But in heme synthesis, it mainly involves the two enzymes. One is your ALA dehydratase and the last enzyme, which is the ferrochelatase. These steps are the step 2 of heme synthesis and the last step that is the ferrochelatase. Coming to the ALA dehydratase. So, what is the function of this ALA dehydratase is this two molecule of ALA combines together with one removal of one molecule of water and forms the PBG. PBG is porphobilinogen. So, can you see this? So, this is the second step. So, where two molecules of ALA combines together to form the PBG. The enzyme is delta ALA dehydratase. So, this is the enzyme which is involved in lead toxicity. The other enzyme which is involved in lead toxicity is the last enzyme, that is your ferrochelatase. It converts protoporphyrin 9 to heme. So, it is mainly helpful for the incorporation of this ferrous iron into the heme. So, because of this absence, it is said that anemia is the most common symptom that is seen in lead poisoning. So, in case of any porphyrias, anemia is seen, it can be easily said that you can rule out the congenital type, and most probably it will mainly be because of the lead toxicity, that is your acquired porphyrias. So, coming to the lead toxicity symptoms, it has got a wide variety of symptoms: irritability, abdominal pain, sleeplessness, headache, constipation, poor appetite as well as lethargy. These are some of the commonest symptoms seen in lead toxicity. So, we go on to the disorders of heme synthesis, that is your congenital porphyrias. So, porphyrias are a group of inborn error of metabolism usually associated with the biosynthesis of heme. So, porphyria means it is purple because there is an accumulation of either the porphyrinogens, or in case the porphyrinogens are accumulated when they are exposed to sunlight, they get converted to porphyrias, and this is why they are called as purple. That is why they are called as porphyrias. So, these are actually characterized by increase in the production of either or excretion of the porphyrins. So, either the porphyrinogens or porphyrins, there is increased production as well as excretion, and even the precursors, something like your ALA or PBG, can also be excreted in urine. So, usually they say that many of the porphyrias are inherited as autosomal dominant except one. So, we will go through one by one, which is that exception also we will learn. So, coming to the types of porphyrias, we have something called as a hepatic porphyria, where the liver is the main thing that is being involved, erythropoietic porphyria, and porphyria having both your erythropoietic as well as hepatic abnormalities. We have learnt during the heme synthesis that in bone marrow almost 80% of the heme synthesis occurs, and the other major site is liver. So, that means any problem with the hepatic, it is called as hepatic porphyria. Any problem with the bone marrow, it is called as erythropoietic porphyria. There are some diseases which is having both the problems, that means either the liver or the bone marrow is involved. In such cases, it will have the porphyrias or both the types. So, we have different types. Coming to the hepatic porphyrias, it is usually the autosomal dominant type. The acute attack is mainly precipitated by drugs, alcohol, stress as well as starvation. There are three types in this, mainly the acute intermittent porphyria, hereditary coproporphyria and variegate porphyria. So, these are the three types which is having the hepatic. Coming to the erythroid porphyria. So, erythroid porphyria is usually a chronic porphyria and cutaneous symptoms predominant. So, usually erythroid will have a chronic course and cutaneous symptoms predominant. The types are congenital erythropoietic porphyria and mixed type porphyria cutanea tarda. So, these are the hepatic as well as erythroid types of porphyrias. Coming to the treatment of porphyria, they said that administration of hemin, this hemin provides a negative feedback inhibition which will help to alleviate the biosynthetic, that means it inhibits the biosynthetic pathway and therefore prevents the accumulation of this heme precursors. So, that is why administration of hemin is a very good treatment of most of the types of porphyrias. So, we have discussed the steps of heme synthesis. So, along with that, the relevant porphyrias or the disorders we will just go through one by one. So, delta ALA dehydratase, the porphyria associated is delta ALA dehydratase porphyria. PBG deaminase, the porphyria is acute intermittent porphyria. Uroporphyrinogen co-synthesis, congenital erythropoietic porphyria. Uroporphyrinogen decarboxylation is porphyria cutanea tarda. Coproporphyrinogen oxidation is hereditary coproporphyria. Protoporphyrinogen oxidase is variegate porphyria, and the ferrochelatase is erythropoietic protoporphyria. So, these are the disorders. Any enzyme defects in this will cause this diseases. Okay. So, of this they say that acute intermittent porphyria is the most common. The second most common is porphyria cutanea tarda. So, usually questions will be asked on either the acute intermittent porphyria or the second one, but for everyone you should know what are the lab investigations and the enzyme defect. So, we already discussed the enzyme defects of each one. We will go through the most common thing, that is your acute intermittent porphyria and porphyria cutanea tarda in detail. The other lab investigations of the other things also we will go through in the next few slides. So, these are the different types of porphyria along with the enzyme defects. So, coming to the acute intermittent porphyria. So, it is the most common porphyria, that is the congenital type which is actually being seen. It is a hepatic in nature, it is also the autosomal dominant. It is caused by deficiency in the enzyme PBG deaminase, that is your porphobilinogen deaminase, which gets involved in the conversion of PBG to hydroxymethylbilin. Because of this enzyme defect, the PBG and delta aminolevulinic acids accumulate both in the plasma as well as in urine. That means there is no accumulation of either the porphyrinogens or porphyrins. That means there is no photosensitivity or any of the things that is being seen in this type of porphyria. Patients usually have a neuropsychiatric symptoms and majorly the abdominal symptoms. Acute is majorly precipitated by starvation. It is alleviated, that means it is relieved by high carbohydrate diet. So, if patient with porphyria comes, high dose of glucose if it is given, the symptoms usually subside. Barbiturates treatment can precipitate the attack. It is also called as little imitator. So, what exactly happens is most of these patients come with the symptoms of abdominal pain. So, most of the things, the scan will be done, all other investigations, CT scan or the ultrasound scan will be done. But after ruling out, sometimes it has gone to an extent that they open up the abdomen and check for any of the infectious conditions, but still no infections will be found. So, that is why it is called as little imitator. That means it imitates most of the abdominal conditions. Neurological abdomination is more common. Sensory and motor disturbance, especially the confusion and agitation, is most common. You must have heard of a person by name King George III. So, this King George III, he suffered from maniac. That means he took some irrational decisions which was in favor or out of favor for the people. So, because he was suffering from this acute intermittent porphyria maniac disease, that is why he took this decision. After the later stage, he was diagnosed with acute intermittent porphyria. Then they realized that this king was maniac because of this acute intermittent porphyria. So, I told you, usually the abdominal pain is seen, some of the cutaneous manifestations you can see. So, ALA and PBG are the ones which gets accumulated both in urine as well as plasma. So, there is no photosensitivity that is seen in acute intermittent porphyria. Coming to the next condition, which is called as Porphyria cutanea tarda. You must have seen some devil movies where at night they have that glowing teeth, the sharp teeth, all those things, and usually when they come out in the sunlight, they will not be able to sustain the sunlight because of the thing. What if I say that that might be because of some of the disorder, that is your Porphyria cutanea tarda. So, what exactly happens is, whenever such patients come out, usually the porphyrinogens which is accumulated is converted to porphyrins. Usually these porphyrins are colored substances and they can cause degeneration of the skin because of the oxygen radicals. So, because of this, the skin, everything is denatured. That means you will have those peculiar ghost like features. Along with that, once these porphyrins are deposited in the teeth, you will have the fluorescent at night. So, this Porphyria cutanea tarda is the second most type of porphyrias, and in this photosensitivity is most common. So, it is hepatic, it is autosomal dominant, it is caused by deficiency in uroporphyrinogen decarboxylase. This is used in the conversion of uroporphyrinogen 3 to coproporphyrinogen 3. So, because of this, uroporphyrinogen accumulates in the urine. Once this uroporphyrinogen is exposed to sunlight or abdominal atmosphere, it gets converted to protoporphyrin. Once the porphyrins are formed, because of this, the porphyrins gets accumulated. So, what happens? Accumulation of the porphyrinogens results in it gets converted to porphyrins when the light is being exposed. So, once the porphyrins are formed, they react with the molecular oxygen and form the oxygen radicals. So, because of this, they can cause severe damage to the skin. Can you see this? This is a typical ghost like features, which is most common feature which is seen in Porphyria cutanea tarda and most of the porphyrias, except the acute intermittent porphyria, because in that porphyrinogens are not being formed. So, usually there is a change in the color of the urine. See, this is the normal urine. There is a change in the color because the porphyrinogens which is accumulated gets converted to porphyrins and see, this is the dark colored urine which is seen in Porphyria cutanea tarda. So, can you see this? This is the UV illuminated. When there is fluorescent, this porphyrins can start accumulating in the teeth and can cause fluorescent at night. That means that typical ghost like feeling will be there. So, this is also one of the commonest feature of Porphyria cutanea tarda. Along with that, you will have the skin lesions because of the damage of oxygen free radicals. So, these are the different types of porphyrias along with the commonest disorders that is associated. But we will have to go through what are the lab investigations we see in each type of porphyrias. So, this is the table showing the porphyrias, but we have kept a separate table. The first one is ALA dehydratase porphyria. So, usually in urine, ALA is increased, urine PBG is normal, RBC HMBS, that is hydroxymethyl synthase, is also normal. Whereas AIP, that is your acute intermittent porphyria, that is PBG deaminase deficiency. So, this is the most common. So, what is that is being increased in urine is it is urine ALA and PBG, whereas plasma porphyrins are actually normal. There is no fluorescence because the plasma porphyrins are actually normal. So, this is the examples of porphyrias with neurovisceral manifestations. Coming to the other types, hereditary coproporphyria. The enzyme defect is coproporphyrinogen oxidase. Usually in the urine, ALA is normal, but PBG will start accumulating. Plasma porphyrins are usually normal. The other type is variegate porphyria. The enzyme defect is protoporphyrinogen oxidase. Usually it is the enzyme 6. So, what are the lab investigations? Urine ALA is normal, urinary PBG is present, but here the urine porphyrins as well as the plasma porphyrins starts accumulating. That means the fluorescent property can be seen in variegate porphyrias. The next one is porphyria with cutaneous manifestations. So, they are having more of a skin manifestations. So, the most common example is the second most type of porphyria, that is your Porphyria cutanea tarda. The enzyme defect is UPG decarboxylase. In RBC, uroporphyrin is increased. In plasma, uroporphyrinogen is present. In urine also, uroporphyrins is increased. So, because of the increase in the porphyrins, there is a fluorescence. The porphyrins can cause the skin damage because of the free radicals. In the next type, the congenital erythroid porphyria, which is because of the UPG3 synthase deficiency, that is your enzyme 3B. In the RBC, both your UP and CP, that is your uroporphyrin and coproporphyrin are increased. In plasma also, both your uroporphyrin and coproporphyrin are increased. In urine also, both your uroporphyrin and coproporphyrinogens are increased. So, that means even this congenital erythroid porphyria can also have photosensitivity because of the accumulation of porphyrins. The next one is erythropoietic protoporphyrin. It is mainly because of the ferrochelatase defect. RBC protoporphyrin is increased, plasma protoporphyrin and urine protoporphyrin is also increased. So, because of the accumulation of porphyrins, even this erythropoietic protoporphyria can also have this fluorescence because of the accumulation of your porphyrins. So, always remember, so these are the things, because of the accumulation of porphyrinogens or porphyrins, there is something called as a photoemissions, so which gives that devilish appearance at night. And the second most important thing is anemia, which is the most common feature of lead, that is your acquired porphyrias, is usually not at all seen in congenital type. Any of the type, either your hepatic or erythropoid, any of the type of porphyrias, anemia is not seen. So, in this session, we have discussed about the acquired type and congenital type of disorders. So, both the disorders we have completed. Thank you.